Good afternoon. First, I want to thank the AAO, especially the scientific committee, Drs. Music and Jim Vaden, for the opportunity, and to encourage each of you to support the AAO. It's an honor. Two people I'd like to thank also are Dr. Peter Busheng, who has been a great influence in my thinking and my writing in science and in orthodontics, and to Dr. Larry White, who's suggested my name to the scientific committee. So I'd like to thank both of you. And of course my family. I couldn't be here if they wouldn't support me. My name is Renato Martins. I'm from Brazil, as you might notice from my accent. I'm in clinical practice since 2002. I did a postdoc for some time at Baylor. And currently I'm the associate editor of the Dental Press Journal of Orthodontics, which is the official publication of the Brazilian Association of Orthodontics and of the Brazilian Board of Orthodontics. Also the assistant editor of the Dental Press Clinical Journal, where I have a biomechanics column where I write almost every edition. Currently I'm an adjunct professor in Araraquara, my city in Brazil, where I'm a part-time, a volunteer professor there. And I'm also a visiting professor at Jacksonville University in Florida. So this lecture is about a way to try to increase efficiency in vertical correction. That's what I would like to talk to you about today. So the search for efficiency hasn't stopped. We as orthodontists and as clinicians, we would like to make our treatment faster, maybe spend less money trying to make it more efficient for us and for our patients. And in order to look for efficiency, it's an interesting idea to divide treatment, the orthodontic treatment, into four phases. Into alignment, transverse correction, the vertical correction, the AP correction, and finishing. And it's a good idea to try to relate those into the treatment time. So by far, we know that AP correction and vertical corrections are the periods of time that takes more time to be treated in orthodontics, in our orthodontic protocol. And we know that, for example, alignment doesn't take much. Well, the literature has clarified some of the AP correction for us. For example, we know that if we treat severe class 2s with upper bias extraction rather than trying four bicuspid extractions or treating non-extraction, we would save a little time. So like we did with this girl. So she's a severe class 2 and we treated her with 2 upper bias. So it was a rather fast treatment. The literature also tells us that if we have a non-compliant patient using elastics, we could replace those elastics for an intraoral functional correction appliance, like forceps, for example. And in roughly 3 months, as my clinical experience tells me, we can get an overcorrection of that class 2. So that saves time. However, people have tried to look into increasing efficiency by trying to improve the phase of treatment which lasts the least time. People have tried to use the so-called frictionless brackets during the alignment phase, which is the phase that, in my opinion, takes the least time to be completed. And of course, you can align teeth well with those brackets, but you're not going to save enough time. You're not going to save time when you use them, because you can do pretty much the same thing with conventional brackets in the same amount of time. But what about the vertical? On the two opposite extremes, we have the open and deep bites. So we can talk about them a little bit. Let's start with the open bites, because they're easier to manage, assuming we are talking about an average corporation patient, and they affect far less people than deep bites. So this girl is being treated with lingual appliances in the upper arch and with ceramic brackets in the lower. And she's using triangle elastics in both sides. So we're hoping that the elastics can help the NITI, the 014 NITI, to level the occlusion. And as she uses the elastic, and the elastic adds force to the leveling wire, we can get her into a good occlusion. Likewise, we have sometimes an open bite with divergent occlusal planes, and the literature tells us that we can treat those cases with reverse curve niti and anterior box elastics. And we can close that bite if the patient helps us. Here's the superimposition. We can see that we get a conversion of both upper and lower plane. But on a deep bite, it's a completely different story. We don't have the elastics to help us out, not even if the patient cooperates, because on the deep bite it's different. Today we might get help from skeletal anchorage, but we certainly don't use a skeletal anchorage in all of our patients. Moreover, the deep bite affects 20% of the population when compared to the 0.5% of the open bites. So it's very much important for our practice to learn how to treat deep bites than open bites, just because we have more patients with deep bites. But what's the problem with the deep bite? The problem with the deep bite with current orthodontics is that we need to wait for the leveling wires, for the aligning wires, to correct rotations before we can access the vertical. So somewhat, I kind of make a joke sometimes with some friends. I say that the orthodontic device is rather, has a little defect on it. Because we need to cross our arms, we have to wait for the teeth to be aligned, and only then we can move past the arch wires and we can start treating the vertical. Because the round, flexible niti wire is not going to treat the vertical. So this is the day we placed a 16 by 22 stainless steel wire into this patient, and we can see that the round and the rectangular niti haven't done much for that patient, for the vertical. It's only the stainless steel that's going to actually treat the vertical sufficiently for us to finish the case. So again, the current orthodontic techniques, almost all of them, they make us wait for the aligning to occur before we can access the vertical. That's the big issue. And there's one person to blame. In the 20s, Dr. Engel, he switched the insertion of the arch wires. He moved from a ribbon-wise approach to an edge-wise approach. So he traded off flexibility in the vertical to get a stiffer wire transversely, because his objective was to expand the arch wires. So he wanted more strength or more rigidity on the wires transversely. So we remove it from second order and add it to the first order. So that's the reason why it's so hard for us to correct second order problems. And we all know that we need stiffness to correct second order problems. Moreover, the literature has shown us that we don't need that much stiffness to expand the arch wires. We can do a lot with copper niti wires, rectangular copper niti. We can expand intermolar into premolar width up to 2 millimeters. We could possibly expand it further. But of course, that's limited to what we need or what we want, and that's limited to the size of the arch wire. Following on that lead, some have tried to add reverse curvature to nickel titanium wires in order to increase the flexion and the force produced. When you have a patient with a deep bite, and you might add some curvature to the nickel titanium, you're going to add deflection to it. As you add deflection, you increase the force vertically without changing the force transversely or the force to alignment. So a lot of people have done this in the past or currently. But even then, it doesn't solve our problem. You got to wait for the round niti wire to align teeth. Even if you put reverse curve to a round wire, a round night-tie wire, it's not going to work because the force is so low. And then you add your reverse curve, and you wait, and you wait, and you wait until you get a flat occlusal plane on the lower arch. Then, of course, you can bond your second molars, and you can finish your case. But you have to wait. Adding reverse curves is, of course, a lot better than not doing anything, but it doesn't solve the problem. So there's something we have tried for some time now, I think since 2005, 2004 in the office. It's the addition of cantilevers. So we have this patient over here, and what we've managed to do, and of course we don't try to say that we invented this because I'm pretty sure that a lot of people have used this currently in the past. We add 2 cantilevers over the flexible arch wire. So this patient has an 014 night-tie in the lower arch, and we place 2 cantilevers, 2 17 by 25 cantilevers over the arch wire. So the idea behind this is that as we have the 014 night-tie aligning the teeth, we have the 17 by 25 stainless steel wire leveling the arch all at the same time, which I think is a smart idea, instead of waiting for one thing to happen first and the other further down the road. How does that work? We place the cantilever, we activate it. With around 80 grams, we don't want to bring the force higher than 80 grams because that force is going to be applied in the molars as well, and we don't want the molars to extrude. That cantilever is going to apply a vertical force, an intrusive force anteriorly in the arch wire, very close to the axis of resistance of the incisors. And it's going to produce a tipping crown moment distally in the molars. It pretty much is going to act like a reverse curve. But you can do it right away in the first day. Your patients, you put your 014 night-tie in. So this is her. And 2 months after, 2 months, we planified the curve of speed, the lower curve of speed, and we didn't even give time for the rotations to be corrected on the canines. So the leveling occurred even faster than planned. So of course we think that's a good idea. And from then on, we can finish the case. We don't have to wait. That's the initial position of the incisor, the lower incisor. That's the finish. And we can see that you don't get much proclination of the incisors when you do this. You don't get excessive. Of course, you're going to have some proclination, but it's not excessive. If you don't want to use a helix, you can use a beta titanium wire, like this case. You can use either a 17 by 25 or a 19 by 25. And another thing that this cantilever can do is to push down or to push apically the leveling arch wire. In those, on those very deep curve of speeds, we can have the canines which are with the crown tipping back, and that can bring the incisors to a more occlusal position and maybe cause some round tripping during leveling. So we believe that when you put this cantilever in, it will also keep the incisors from going occlusally too much. So we can see that we can get the leveling that we want, I believe, in a faster time than if we wait for everything to occur like we're used to. There's another girl, and as you can see, we don't need to bend the molars. You can use it with a bonded tube. It only has to be a double tube. That's the only thing that you need to add to your inventory. This is a 17 by 25 stainless steel placed over a 014 night-tie. This on the next month when we placed a rectangular 16 by 22, you can keep the cantilever there. And then you can finish your treatment. This is another patient with linguals in the upper, where we did the same thing. In a curious way, one of the sides has been corrected earlier than the other one. And we've used on several patients this cantilever unilaterally, and there's no problem with it as well. So that's her. 014 eye tie, 17 by 25 cantilever over it. Rectangular eye tie, we removed the cantilever. 16 by 22 stainless steel. By the way, I'm on 018 guy, so that's where we finish. And I would like to finish with a clinical case, which we used this technique. She was a class 2 adult patient, severe class 2 in one side. Retrocline upper incisor. So we placed the 014 eye tie in the lower arch, beta titanium cantilever 17 by 25 over the arch wire. We're going to extract upper bias. We used the segmental approach, and the reason why I put this case in is that this technique that I'm talking to you about, to place the cantilever over the flexible eye tie wire, it doesn't matter which prescription bracket you use, which technique you're using, it can be applied to all of them. So it's sort of a universal solution. That's her after we got the canines to their position. We had to fix or correct the tipping back of the crowns of the incisors and the canine. And that's her finished with a little bit over 2 years of treatment time. That's her finished x-rays. So her final tracing, her initial one. On the superimposition, we can see that we did not get a lot of proclination, maybe 1 or 3 degrees, 1 to 2 or 3 degrees. We also did a lot of IPR on that patient, so that's why we didn't get a lot of proclination as well. And the take-home message is that conventional appliances, they show stiffness deficiency in second order, in the vertical. So simultaneously leveling with the alignment at the same time may be advantageous when we compare those two phases being done at different times. So in order to be more efficient, we're doing at the same time things that normally we do at 2 different periods of time. And 2 little pieces of wire, along with double tubes in the lower molars, can possibly make treatment more efficient. Nothing else. I wrote a paper about this presentation, so I had enough time to do it. And it's on the current edition of the Dental Press Journal. And instead of bringing it to you guys and to distribute the handouts, I've added, the AAO was kind enough to put it online to distribute to any of you, so you can download it and read it. And I've also added a QR code. I went to VCU I think earlier last year, and some of the students filmed me bending this cantilever. I didn't think it was appropriate to show at the presentation today, but if you take a picture of the QR code, you can see the video and download it, so you can see the talk that we have and the explanations of how to bend it out of a 17 by 25 stainless steel wire. So I appreciate your time. Thank you, and I hope to see you again.